It's typical that people living with ARFID eat a very limited variety or amount of food, and this is where the biggest difference lies, leads to consequences that are significant. So that may be with their general health and nutrition. It may be just growing or maintaining weight or a healthy weight for their size, or in the psychosocial functioning, which is where we can kind of see some gray area between picky eating and ARFID.
Welcome to episode 29 of Eat Your Greens with Dr. Black, where I discuss plant-based nutrition for the whole family. I'm glad you're here. Whether you're a longtime member of the Eat Your Greens family or if you're a brand new listener, I want you to know that I am grateful for each and every one of you. If you haven't yet subscribed, do me a favor. Go to the Eat Your Greens website. That's www.eatgreenswithdrblack.com. Scroll down to the bottom of any page and subscribe. And to show my appreciation, you'll get my free guide with over 20 strategies to help you and your family implement a plant-forward lifestyle. Now, today's episode is an important subject. I've had a number of requests from concerned parents to talk about this topic. You may recall that in my last episode, I spoke with Allie. She was a mom of 3. She was a picky eater herself, and one of her children was a super picky eater. And we talked about how that affected her growing up, how it affects her family, their quality of life. And we discussed a number of strategies that you can implement if you have a kid who's a picky eater. Now, what if your child is picky to the extreme? In fact, so picky that it's affecting their health and they're not able to eat enough food to gain weight, or maybe they're getting malnourished. How do you know? When is it more than just picky eating? Over the years, as a pediatrician, I continue to learn new things all the time, often from my families, from the parents in my practice. And this is one of those examples. Have you ever heard of ARFID, ARFID, Avoidant Restrictive Food Intake Disorder? This is a relatively new diagnosis. It's not a new phenomenon by any means, but it's a newly classified diagnosis. And so even up to maybe 6 months to a year ago, I really hadn't ever heard of this, but I started getting questions about it and seeing it cropping up in the literature. And that's what we're going to talk about today. Now, even if your children are born foodies and will eat anything that you put in front of them, this episode is going to be useful for you because I guarantee that at least somebody in your family, maybe in your extended family, may be affected by a restrictive food intake disorder. Or maybe it's your kid's school friend. Maybe they're going to come over for a sleepover or the birthday party. This episode is going to help raise awareness about what ARFID is. And even if you aren't personally affected, I think you're going to find it useful to be able to support others who are affected by it, and just to understand that feeding is complicated and we should really have a lot of compassion for people who are struggling with eating disorders. Today, I have the great honor to talk to Mo Salari. Mo is a native of Austin, Texas, and a graduate of the University of Texas at San Antonio, where she earned a master's degree in social work. Growing up as a biracial, queer, and neurodivergent individual, they struggled with their own self-image and relationships, and Mo's journey to healing and self-love led her to a career as a clinical therapist. She practices at the Austin Center for Eating Disorders and is passionate about the importance of connection, pleasure, autonomy, and social justice, especially within the therapeutic space. I really appreciate you joining me today, Mo. Do you want to tell me a little bit more about your background and how you developed an interest in feeding disorders and eating disorders?
Yeah, definitely. And I actually get asked this with the people I work with. My personal journey with food, never considered that I had any type of eating problems or struggles myself. Did have some picky eating growing up, but grew out of it kind of naturally. And I'm a big lover of food, but something I bring into my work is just the discussion of how eating is very connected to our emotions, or it can be. And so I talk about that with my clients, that if I'm sad, eating is not going to be at its best. So I've been able to observe that since getting into this work. But what really brought me to it was, I don't know if you're familiar with the podcast, This American Life. It's a lot of storytelling. And one of the producers on there, I believe her name is Susan Burton, she wrote a book called Empty, and it was about her experiences of having an eating disorder and still struggling with it throughout her life into, I believe she's around her 40s. And so that started to pique my interest. And when I got into grad school, my original intention was to work with couples because I was very interested in just diverse and atypical relationships and working with people in love. But because we had a lot of flexibility when I was in school to study what we wanted. And towards the end of my program, I had free range on a project to look into just whatever I wanted. And I started getting into eating disorders. And where I really connect with the eating disorder world is the body image piece and self-esteem, because that was something I struggled with for a long time and have worked really hard to heal within my community and with friends and on my own. It's something I'm very intentional about. And so talking about that with people is just something I'm really passionate about. And so I first started my work in a treatment center, and I worked at Center for Discovery in Austin and had an amazing boss there who provided so much guidance and just I worked with a really great team of varying life backgrounds and experiences, personal experiences with eating disorders. And just, it was a super crash course into learning about eating disorders. And I've just enjoyed the work since. And once I had the opportunity to join the private practice, I took it, and I'm so happy that I did.
So tell me about ARFID. It stands for Avoidant Restrictive Food Intake Disorder. And how does that differ from just picky eating? What is ARFID?
Yeah, so ARFID is a psychiatric condition. So that's, one major difference is it's psychiatric versus picky eating, which is more just kind of considered a behavior. But it's categorized in the DSM as an eating disorder. And it's typical that people living with ARFID eat a very limited variety or amount of food, and this is where the biggest difference lies, leads to consequences that are significant. So that may be with their general health and nutrition. It may be just growing or maintaining weight or a healthy weight for their size, or in the psychosocial functioning, which is where we can kind of see some gray area between picky eating and ARFID. Because, right, if you have a picky eater and this is taking up a lot of energy, it can seem like it's highly impactful in your social environment from a parent to a child.
And you mentioned that it's classified in the DSM. What is that? What does that stand for?
Yeah, the Diagnostic and Statistics Manual.
I believe they're up to number 5 now.
Yes, we're on 5 TR. So what does that stand for? Text reference, I think. So yeah, and there's been some differences in the diagnosis between those since the releasing of 5 in 2013 and the text reference in 2022. Yeah.
If I remember correctly, they just came out with 4 when I was in medical school. It might have even been 3. I don't know. It was a long time ago.
Mm-hmm.
And that's the manual that sets the criteria for diagnosis. So when you're considering whether or not somebody has a psychiatric disorder, the DSM is kind of what lays out what symptoms they have to have, what they have to meet to make that diagnosis. Is that correct?
Exactly.
And so ARFID is classified as a disorder in the DSM-5. And so my understanding from what you said is that it's just much more severe than standard picky eating and actually has some health consequences, both physical health consequences, but also mental health consequences. Do I understand that correctly?
Yeah. So to qualify for the diagnosis of ARFID, we're looking for one of the 4, and I'll go through exactly what it says in the DSM. The first would be significant weight loss or failure to achieve expected weight gain or faltering growth in children. So maybe they're not following their growth chart. And I'll talk about what's kind of difficult in determining these things within the different criteria. For this one, if your child has always struggled with eating since birth, maybe you can't exactly detect that they're faltering in growth because they've always just, maintained being pretty small. And so that makes sense in their curve. The second would be a significant nutritional deficiency. So, usually, you can speak more to this, you're not usually taking children's blood and running tests and all of that unless you're seeing some kind of problem, right?
Correct. Right. If we see that they're consistently, we call it falling off their growth curve, right? So they're dropping percentiles. Their growth curve is flatter than it should be on more than one visit. And there's a concern, then we start drawing blood. Sometimes we do some x-rays to look at how their bones are maturing and try to figure out what's going on.
Yeah. And I imagine that to the point where you get to drawing labs, we really have to draw on parental experience and what you're observing or what the community around the child is observing. If you're noticing your child is really tired compared to other kids, or just, I would say that's like a big indicator, but sometimes it can evolve into much more of a larger crisis that like regular functioning, walking, cognition, those kinds of things are often that leads you to see a physician. And that's where we start seeing these nutritional deficiencies. So that's really important for a parent to just be observing differences. So yeah, significant nutritional deficiency. And then dependence on an enteral feeding or oral nutritional supplement. So if your child is getting most of their nutritional requirements from, a lot of vitamins, or if they've had to be on like a feeding tube, that is going to be a marker of ARFID. Is that what that means, the enteral feeding?
Enteral means, it means through the gut. Okay. So it would be nutrition given through like a nasogastric tube, a tube placed through the nose into the stomach. In extreme cases where they need that long term, then they'll put a G tube. They'll do a surgical procedure called a gastrostomy and put a permanent tube into the hole there. And then you just put food directly into the stomach. And my special needs daughter has a G tube because of her seizure. She had a time where she really couldn't eat or drink because she was either having a seizure or recovering from the seizure drugs and she wasn't growing. So she has a G tube for that, but enteral just means into the gut versus like an IV, something like that puts the nutrition right into the blood.
Gotcha. The last one is that marked interference with psychosocial functioning, which is really going to vary based on the family, especially if you've had children prior to your child with ARFID and you've been, the other children have been at peace with food. It's been with ease. It might feel really significant that your child is eating totally different food and there might be a lot of fights. So that part is where we get a lot of gray area if there is a child or someone meeting criteria for the psychosocial functioning, because it's just very subjective.
Right. Yeah. From family to family and that dynamic. Do we know what causes it and what are some risk factors that somebody might have that puts them at risk for developing such a severe disorder?
Yeah. So as far as risk factors go, so ARFID is a relatively new diagnosis. And I imagine a lot of my answers to your questions are going to be like, we're still learning, because that's what's happening. A lot of research is being conducted. But what we're seeing with who's at risk of developing ARFID is people with sensory sensitivity, high anxiety, and just like if you're noticing that there's a low appetite, that's what's going to play into the development. But what research is suggesting so far is that there may be biological contributors. Biomarkers have been largely understudied at this point. So we're still finding all that information out. But there is some indication of, just like with eating disorders, typically there's like a family history. And like a lot of psychiatric disorders, biopsychosocial, all of that is going to contribute to someone being more at risk for this disorder.
When I was looking it up, I came across some references to things like history of choking and so fear of eating. And I recently did have a patient with that history. He was a young teen I can't remember exactly what food he had a choking episode on, and even needed the Heimlich maneuver.
Mm-hmm.
So it was quite distressing and traumatic for him. And then he had a period where he would not eat anything solid. I think he was living on Pediasure or the other like nutritional drinks, and just wouldn't touch food, was really afraid that he was going to choke again. And I think back to my training, and we would have micro preemies who were in the NICU for a long time, or maybe they were intubated for a long time, or say a child born with a congenital heart defect who was, had major surgery, was in the ICU for a period of time, also intubated. And those children being at higher risk for what we called oral aversion.
Mm-hmm.
So, just having things in their mouth, food and flavors and textures, and really rejecting that and having a hard time starting to eat once they were strong enough and old enough, starting to eat solid food, and really requiring intensive feeding therapy, usually done by a speech therapist who did stimulation of various textures and things in the mouth and gradually helped the child accept those things. And they still do that, I think, with children who have autism, who are very sensory sensitive and resist a lot of things. And then they're at risk of nutritional deficiencies. So in my mind, it seems like that's different variations of ARFID. And maybe I'm overgeneralizing.
No, you are so on target with it, because we've made so much progress in birth, and children with really significant medical problems are able to be born and live, that we're seeing more of these issues. And so that's thought to be one of the contributors as to the rise in ARFID. And that's something that I see with the people I work with, especially, when a child comes in with their parent. I've had many parents describe having premature children that had to go through some pretty, intense and traumatic experiences in the hospital, and learning to eat, and having occupational therapists, and working with the applied behavioral analysts. So this is where ARFID really differs from other eating disorders that are restrictive, like anorexia or bulimia, is what's called the different maintaining mechanisms. So you mentioned the fear of adverse experiences or consequences with food. So some people may have had, like you mentioned, a serious choking episode, or very serious instances, or even not so serious subjectively experiences with vomiting or diarrhea or allergic reactions that have led them to reject certain foods, or maybe even total food categories, or just fear the process of eating altogether. I even work with some people who've not had these experiences, but so fear having them, such as they have allergies in other parts of their life, but they're afraid to go into anaphylactic shock. And so that is one of the maintaining mechanisms, is fear of adverse experiences. And then another one of the three is the sensory issues, which I mentioned earlier. So some people with ARFID find that food outside of their safe foods have strange or intense textures, taste, or smells. Some people with ARFID are said or thought to be super tasters. I don't know if you've heard of that. Just having more taste buds and sensitivity to taste. I work with people who, between the same products, their safe foods that they eat, every day, they can taste the slightest difference in the manufacturing of that product. And that can sometimes lead to losing their safe food. And so that's a common struggle that I see with the people who are heightened in the sensory area. And then the last one is just like a general lack of interest in food. So they feel like eating is a chore, or they get full very quickly. And I see this one a lot with ADHD. There's the low interest. They're doing other things. And, it leads to one of the consequences we talked about earlier. So yeah, those are three maintaining mechanisms.
And you had started to say how it differs from other eating disorders like anorexia and bulimia. And I believe with anorexia, that's more of a weight issue, wanting to lose weight, or a body image, believing that your body doesn't look right, it's not the right shape, and this desire to be ultra thin or lose weight. Whereas with ARFID, if I understand it correctly, weight loss is not a concern. It's more anxiety, as you were just saying, anxiety and fear for one reason or another related to eating, or that sensitivity, hypersensitivity to flavors and textures that limits it. So the people with ARFID aren't trying to lose weight. They're not trying to restrict their intake to maintain a certain body shape or image. Is that correct?
Yeah, that's correct. They're not concerned with weight. And I work with people with ARFID across the weight spectrum. This is just like all eating disorders. You're not going to find a typical shape in ARFID. And often the people who are of lower weight are concerned with gaining weight because they know that it's important. So yeah, if they do have the concern with weight, that is going to be one of the things that actually rules them out of the diagnosis. And they might be more so in the, what's called like ASFED, like other specified feeding or eating disorder. So not a concern with weight.
Does it always start in childhood?
So actually in the original diagnosis for the DSM-5 in 2013, it did include an age of onset criteria, but when we got the TR, that's when they removed that criteria, and that was to cover the group of people who have had a adverse consequence later in life. So no, it's not always childhood onset.
So it can start at any age, even like you said, for even young infants from birth on.
Yes.
Once you have a patient that's referred to you and you see that they meet the diagnostic criteria, what are some of the treatment modalities? How do you help people with ARFID?
Yeah, so typically by the time someone has made it to me, hopefully they're working with a doctor. That's going to be a critical part. So the first step is really getting the treatment team established, because if we are in ARFID territory, it's not something really appropriate for parents to address on their own at home. So we'll want to make sure that they have a full treatment team, which typically encompasses a physician that can monitor their health, a dietitian that's going to help with the guidance of what can we add in here to make sure that we're meeting nutritional requirements for growth. And then the therapist, my role, is going to be doing a lot of the psychological work. And between the dietitian and therapist, especially, I'm really fortunate to work at a practice that we have dietitians and we work closely together. We'll be working together to do exposure work with food. Like I said earlier, as a new diagnosis, as far as research goes, there is not a whole lot out there about what is the most effective, but what we are finding and what is promising is cognitive behavioral therapy modified specifically for ARFID. And where that comes from is that CBT, shortened for cognitive behavioral therapy, has been found to be very effective for the treatment of eating disorders, pediatric feeding disorders. And so CBT AR is CBT ARFID, has been adapted from those modalities and that work. And it includes, the typical psychoeducation, learning about the disorder, and then coming up with a plan to start integrating more variety and volume if appropriate. And yeah, it's a lot of exposure work.
I imagine it takes quite a long time.
It can, but it just really depends. Sometimes we're overcoming a lot of fear before we can take those steps to start increasing variety. And sometimes there's just so many different barriers that people can come up against to do both of those things of increasing volume or variety. So it just really depends.
How often have you found, or is it reported to be successfully treated so that people can overcome these barriers to eating and, feeling safe when eating and be able to meet their nutritional needs and just the quality of life? Do you have any ideas on what the success rate is for treatment?
Yeah. So as far as like official data, again, we're still developing research, but CBT ARFID is showing positive outcomes, and people going through the treatment are showing sustained improvements in variety and volume. And in my personal work, I see it working. I will say motivation is really key, and that is typically when I have adults coming in, they're like, I need to get over this. I need to work on this, and they take it very seriously. But that can really vary for kids. Some children aren't seeing how is this impacting my life, especially if that medical piece isn't there. But even for some of my children that I work with, that the medical piece is there, there's just such a great fear to overcome. And so, yeah, results may vary, but
Right.
something else important I do want to mention is just like a little bit more on that biological piece, because it's thought that since there is a biological origins, that it is in some way related to evolution. Basically, the idea is that during hunter-gatherer time, so way far back, that people then became accustomed to be very careful about what they picked as far as veggies, fruit, meat, because you could poison yourself. And so it's thought that some of those blockers that helped people to protect themselves from becoming very sick may still be with people who struggle with ARFID, that make that fear so strong. So I think that's really important to consider. And that's part of the therapeutic stance, that nobody is to blame here. This is a psychiatric disorder, just like we wouldn't shake someone with depression and be like, get over it, or somebody with autism. It's something we've got to work with and manage through.
So, yeah, it's always interesting to me to hear some of the theories about how these disorders may have roots in evolution going back. And my listeners will not be at all surprised to hear me say, I wonder how changes in our gut microbiome are affecting the rates of this disorder, because I think there is growing evidence that the types of bacteria that live not only in our gut, but also our mouth, can play a role in how we experience flavor and texture, and can influence cravings for certain foods. So I wonder, as the makeup of the gut microbiome has changed with our changing diets over the last few hundred years, if there's any evidence that that's having an effect. And I suspect the answer is not yet, or we need more evidence. They're studying it.
Yeah, definitely. I haven't come across any literature discussing that, but everything you're saying makes total sense. And I think that combined with this like evolutionary theory and thinking about, because a lot of people with ARFID find safety and comfort in carbohydrates. And so I imagine that both of those play together to impact that feeling of safety.
Do you have an idea of the rate of ARFID? What percentage of the population is affected? And is that number changing? Is it just that we're now recognizing it more, or do you think it's becoming more common?
So with the emergence of the diagnosis, it's definitely we're seeing a rise, but that's partially due to the presence of the diagnosis. Whereas like before, people were being probably classified in that OSFED category for the eating disorder. Now we have a name to put to it. But yeah, as far as presence in just the general population, we don't have data on that specifically. I will say that it is heterogeneous, so it's affecting people across the lifespan, both or all genders, and across race. It's very diverse. It's not specific to women, men, people with autism.
Tell me a little bit about the link between ARFID and autism, because I think my preconceived notion before I knew more about it was that it was mostly people on the autism spectrum that were affected by this, but I now know that that's not true.
Yeah, to answer the question, no, it's not always associated with autism, but we are seeing high comorbidity between neurodivergence in general. So I see a lot in my personal experience, I'm seeing a lot of people with autism and ADHD with ARFID, but it's also found to be comorbid with people with anxiety disorders, oppositional defiance disorder, which I think is interesting. However, just like the rest of this, it's so new. We're not sure exactly where the data is regarding psychiatric comorbidity and personality styles in ARFID compared to other eating disorders. But like I mentioned earlier, I think the big crossover is that sensory awareness and sensitivity is why we see it between neurodivergence and ARFID.
Makes sense. If a parent has a kid who they either know already have the diagnosis or suspect that they have the diagnosis, what are some things that parents can do at home in addition to seeking professional help?
Yeah, so kind of between picky eating and ARFID, the bigger frame of thought is gentle approaches. A lot of clinicians believe that parents should not force feed their children. I hold the same stance, and ARFID treatment does not go about force feeding. And it's a process that requires a lot of patience. And so that's my first recommendation, is to just be very patient with the process. It can be very scary, obviously, if your child is in a life-threatening or severely malnourished because of the diagnosis. And so working with a team to figure out where can we fill in the gaps to make sure that nutritional needs are being met is going to be the first step. And after we get to that point of like, my child is okay, my child is nourished, that's when we can slow down and emphasize the patience. After that, I do recommend, especially parents of children with more severe cases, I recommend joining support groups, because it can feel, as a parent myself of a traditional picky eater, it's very stressful. And so having the support of other parents going through this experience with their children, I think, is really important. And then just making sure to follow through with interventions that are set by the treatment team and get all the coaching that is necessary to get through that process is going to be really critical in overcoming ARFID.
Thank you for those suggestions. It mirrors a lot of what Allie and I talked about on the last episode that was just about general picky eating, and in terms of having some boundaries and guidelines, but also the need to be flexible, and being overly rigid is going to backfire. And that's definitely true in this case, even more so. You know, if you have a child who's actually afraid to eat or is so averse to the experience of eating, if you're forcing them or being very heavy-handed, I think it's just going to reinforce that fear. They're going to have less of a feeling of control over the whole eating process. And I think that's just going to make things worse. So that compassionate, gentle, patient approach is crucial, I think. And that's of course true for probably any aspect of parenting.
Right.
Although I always like to point out that parents are humans too, and often are tired and stressed out. And sometimes our capacity to respond with wisdom, may be limited. And so we just do our best from moment to moment. And sometimes we get it right and sometimes we don't. But it's good to hear that message repeated, like approach it with love, with patience, and, work with your mental health provider, your therapist, or your speech therapist, whichever professional you're working with to help your child. What are some resources that parents might be able to access to learn more about it, or if they think their child might have it? Are there online support groups? What can we do to start helping families while we're in the process of referring to a therapist like yourself?
One resource I like to plug is the ARFID Collaborative. That's an online organization, and that's a great place for people to start. They have a resource page with a list of support groups for caregivers and people struggling with ARFID, and then different forms of accessible media, videos, podcasts. Not a lot of literature currently exists for ARFID, whereas other eating disorders, we've got so many books for both caregivers and the people struggling with eating disorders. There's not a ton of books about ARFID itself, but I definitely would refer to the ARFID Collaborative as a place to start for caregivers and people struggling with ARFID.
Great. I'm sure my listeners who may be affected by that really appreciate hearing that, and really appreciate you taking the time out today to educate me and my listeners about this. Sounds like poorly understood disorder with growing understanding, but still a far ways to go. I definitely will be better able to watch out for it in my patients, and I do appreciate that and feel more confident in my ability to support them now. So thank you for taking the time out today to talk to me. I would just like to take a minute sometimes to recap what we talked about, some of the main points. So ARFID is avoidant restrictive food intake disorder, and it's different from picky eating in that it's much more extreme and therefore comes with the negative consequences, the health effects of things like inability to maintain a healthy weight or weight loss, nutritional deficiencies, and often is associated with a lot of anxiety or extreme fear related to eating, or it may be associated with sensory disorder like autism spectrum, maybe ADHD or other neuropsychological disorders. It can start at any age, but is most often starts in childhood. Mm-hmm. There are some criteria that have to be met, and when we suspect it, we can refer you to a trained therapist like yourself who can determine, does this individual meet the criteria? And the treatment is mostly psychological, so cognitive behavioral therapy and some exposure therapy. It is treatable, but we don't yet know what percentage of the population is affected by it, and the success rate is going to vary on a case-by-case basis, but it is very treatable, so there's hope. And there are some basic things that families can do at home, but really it's crucial to reach out. And I really appreciate your suggestion about finding a support group. That was true for us as my daughter when she started having seizures when she was very young, and we got her genetic diagnosis. And it was a rare diagnosis, so having a group of other parents who had children with the same disorder was very helpful. So I appreciate that so much. Find other families who are dealing with it and connect with them.
I think you got everything. Good synthesis. Thanks so much for having me. I love to talk about ARFID and eating disorders, and it's important work, and there's still so much to learn, and I just appreciate the time to talk about it.
Hopefully we'll get the opportunity in the future to talk again.
Yeah, absolutely. Thanks for having me.
Hey, if you know someone who would benefit from this information, please tell them about the Eat Your Greens podcast. Tell them about the website, www.eatgreenswithdrblack.com. And also, if you have a sec, just go on your podcast app, take a minute to rate the show and leave a review. It's really helpful in growing the show and getting the word out there. I really appreciate it. Thanks for listening, and don't forget to eat your greens. Please be aware that this podcast provides general health information about nutrition and feeding of infants and children and is meant for educational purposes only. It's not intended to replace the important relationship between a parent, child, and pediatrician. If you have concerns about your child's nutrition, health, or growth, please consult your doctor.